Okay.
All right, we're recording. Thank you.
So thank you, Caitlin, so much for the lovely introduction. And what is so impressive is she got both the Germanic surname and the Aboriginal university name absolutely right. So thank you very much for inviting me to talk with you. It's 8 o'clock in the morning here. From the other side of the world, and I'm really excited to be here and talk about something that I'm quite passionate about.
Next week, just kind of what.
I'm going to begin by acknowledging the country that I am on here in Australia. I'm on Dharawal country, and I would like to pay my respects to elders past, present, and emerging, and also to acknowledge any First Nations people who may be with us today. So I'm going to do two things, I think, in this talk this morning. I'm going to first ask some questions about whether precision public health exacerbates inequalities, and talk about how that might be so or not. And then I'm going to go on to talk about how involving communities can reduce inequities in precision public health research. And because Caitlin encouraged me to do so, I'm going to be doing that predominantly through the lens of work that I've been doing for a few years now on precision public health approaches with general practice data. So a bit more about that later. But first of all, I'm going to talk a little bit about equity and precision public health, and start by observing that it's pretty impossible not to talk about equity when we are talking about precision public health. And that's for at least two reasons. The first one is that notions about precision always involve conversation about numbers, and numbers and justice are bedmates in a sense. They're things, ideas that have long kept company. And you can see that partly simply because the paired words of counting and accounting belong together. So as Yazanov says, if you can count something, you can also account for it. And it wouldn't be surprising then that precision public health, which holds such promise for counting in new and different kinds of ways through greater volumes of data, broader diversity, a broader range of data types, including unstructured data, more frequent data points, more analysed more quickly and changing more often. All of those sorts of things should also raise questions about justice and fairness. And I think secondly, and obviously for many of us, public health is always interested in the conditions that determine people's health and ill health. And since the very beginning of the public health enterprise, those conditions have always involved looking at the social world, where you're born, where you live, where you grow up, your income, your education, housing, race, gender, sexuality, those things that we talk about as the social determinants of health, which are the mainstay of public health activities, mean that we must be interested in equity and inequity. So at the level of individuals, social determinants are somewhat capricious. My children didn't choose to be born in Australia. One of two girls and a boy. They didn't choose, therefore, to have the benefit and burden of parents who were well educated, to grow up in the country with clean air, water, ample food supply, to go to pretty reasonable schools, and to speak English in an English-speaking country. But at a population level, as I'm sure all of you know, those social determinants and the differences in health status that they create, they are not capricious things. They don't happen by chance. We can do something about education, clean air, water, food supply, etc. And so public health is always the science of describing data and how we can improve the population and how we can do something about inequities. So I'm going to talk a little while now about whether precision public health actually does exacerbate inequities and the circumstances under which it might do that. So I'm going to draw here quite heavily on a recent paper in the American Journal of Bioethics, which I think to some degree quite helpfully divides the factors that might contribute to inequities in precision public health into upstream and downstream factors. So Galasso starts by talking about how upstream barriers with respect to precision public health are the kinds of things that prevent people from getting included in precision public health measurement and activities in the first place. They might stop people from engaging in public health if they wanted to. So if we're collecting data about marginalised groups and we are inaccurately representing their experience, those are objective sorts of barriers to upstream barriers to being involved in precision public health. If we are enrolling people in trials, and those trials are mainly online, and we have people who are unfamiliar with information technology, if there's technical language for people with limited scientific education, if the resources and the requests that we provide to people are in English, they are all things that are going to reduce the involvement of people from certain kinds of backgrounds in being included in precision public health activities, and therefore they will make precision public health more inequitable. Secondly, there are what Galasso describes as subjective barriers. So these are the kinds of things that might stop people who might have all the tools that we think they would need to take part in precision public health, but they may not want to. And the kinds of reasons that may be important there are things like mistrust in health systems, mistrust in government. In Australia, for example, one of the main underpinning reasons why we undercount Aboriginal and Torres Strait Islander peoples in many, many, many areas is that people just do not wish to engage with health systems, or they do not wish to engage with government. So they're the upstream sorts of barriers. The downstream barriers, and Galasso suggests that I'm going to get things popping up in odd places here that you may not be able to see. The downstream barriers can also be objective and subjective. So those sorts of barriers are barriers that focus on taking up strategies that have been identified through precision public health research or precision public health approaches. The subjective barriers are going to be those sociocultural factors that might encourage people not to take part in the programs or the strategies that have been identified through public health. The objective barriers, and I think probably they're the more significant ones, are the material obstacles that people have to accessing precision public health outputs. So, for example, if a precision public health program of work identifies a need to establish a new screening program to identify people with specific genetic conditions, but the screening program is only going to be available in large urban areas, then people who are in rural or remote regions may not access it as much. Even with considerable effort to improve upstream inclusion, we might end up with robust and widely applicable precision public health research which is just not going to be picked up, it's not going to be taken up, it's not going to be applied. This is going to be relevant, I think, both to people's access to health services and also to what they do outside of their use of health services with the information that they get about themselves. Even if people learn things that might be relevant for them. Socioeconomic constraints are going to be probably a limiting factor in the empowerment that they can draw on to act on what they learn. As we all know, information doesn't necessarily lead to lifestyle changes, particularly when structural factors are going to make that difficult. So if I know more about the need to eat more fruit and vegetables, that doesn't necessarily increase my consumption of fruit and vegetables when the fruit and vegetables available are much more expensive than other food sources because I'm living 5 hours from a major centre. So that's really the kind of picture I think that Galasso paints about why it is that precision public health might lead to inequities. Despite the usefulness of that approach, I think it probably doesn't push quite far enough to explore the factors that might underpin those barriers. And here, I think, the biggest problem that we are facing is, and you can call it whatever you like, you can call it structural inequity, you can call it oppression. It is the same problem that we have for equity in public health research and research outcomes more generally, which is simply that the solutions to inequitable outcomes in public health tend to lie outside the health system. They lie in the welfare, the housing, the justice, or the education systems. And the reasons often why specific groups are unable to participate in healthcare and public health will be the result of historical and ongoing oppression. I'm very much coming from the perspective of being in an Australian culture where that is blatantly obvious to us every day. It's also the case that when we collect data about groups who are historically oppressed, for example, through their use of health services, sometimes even collecting those data can actually cause harm. And to segue for one moment into a slightly different area, I want to very, very quickly, a different part of the world rather, I want to really quickly just mention an example from the UK about how collecting information about minority groups or vulnerable populations can cause harm. So way back in 2018, the government under Theresa May at the time inserted a requirement into UK law for Home Office reference numbers to be inserted into general practice records. So, and these were reference numbers in relation to immigrants. There was an uproar about the decision to do this. And in May of that year, the government suspended that data sharing agreement between the National Health Service and the Home Office because doctors' groups and health charities were claiming that the practice was actually scaring some patients away, and these are particularly patients from vulnerable populations, including immigrants, from seeking healthcare as part of the National Health Service, and therefore their health problems were not being addressed, thus further exacerbating the inequities. So thinking about oppression and these issues takes us away, I think, from thinking about specific things, whether they're upstream or downstream, with respect to precision public health, as strategies that we might use to address inequities, and takes us far more towards thinking about the institutional, the cultural, the historical, the sociological aims and practices that provide a home for these kinds of techniques in the first place. And that institutional focus raises the level of analysis outside of thinking about upstream and downstream factors and towards the social realities that frame the governance and the goals and the deployment of health-related data science and precision public health more specifically. It's what James Shaw and Sharaf Rasekalil talk about as health data justice. And so their focus is on how a health data justice approach might be able to do something to reduce inequities in data-intensive activities and in precision public health, therefore. So they suggest a range of ways in which researchers can actively go about implementing a health data justice approach. The first of three of which I'm going to very briefly talk about here because they're relevant for where I'm going to go next. First of all, they make the obvious point that if you're going to address inequities and there is oppression and historical marginalisation, then you've got to take that seriously. The institutions of healthcare delivery, research, and innovation actually have harmed communities in important ways, and that generates mistrust over generations, and those histories have to be understood if we're going to meaningfully work towards health data justice. Secondly, we need to build diverse knowledge and experience in health data governance. That means we've got to commit to working with and collaborating with people who have quite different perspectives and life experiences from our own, and engaging with a wide array of disciplines, including the critical social sciences, because they can present different scholarly approaches, different perspectives, and different ways of thinking about data-intensive health innovation. And finally, we need to work hard at building coalitions of action in partnership with community groups. Building trustworthy partnerships with community members who are affected by inequity and related to health, to data science, is going to need time and energy, and it's going to have to be over the long term. And we have to acknowledge that when we are designing research programs and building activities that will seek to reduce these inequities. So with all of that as background, I'm going to now go on and talk for a little bit about how involving communities can reduce inequities in precision public health research. And I'm going to take communities in a very broad and loose kind of way. They may be communities of place, they may be communities of culture, they may be communities of history. I'm going to use the term loosely here to describe people who have some sense of belonging together. And drawing on Shaw and Sekalal, I'm going to suggest a range of ways in which we can involve communities and the public and use examples from recent work, as I said at the beginning, that I've been undertaking with colleagues here in Australia on how we can focus on the use of community involvement in secondary general practice data for research purposes. So this comes from work that is I've been doing with a range of fantastic colleagues across quite a number of institutions and under the auspices of a cooperative research centre called the Digital Health Cooperative Research Centre. Before I get to the findings and the work that we've been doing, I probably, particularly for this audience, need to say a couple of things about general practice in Australia. First point is general practice in Australia is a form of medical practice, and it is designed to be comprehensive, continuing and whole person care. It is the first point of contact for most people with the healthcare system, and it is the gateway to most other healthcare services. You can't access healthcare specialists other than through general practices for the most part. We have about 6,500 accredited general practices across the country. Those services, the services they provide, are partially subsidised through universal public health insurance, and the services are free to some vulnerable populations. We're in the middle of a push to register patients with single practices. We can't enforce that in this country, but that would eventually make the delivery of services probably a little more like the United Kingdom National Health Service. It probably goes without saying, but general practices now almost universally have electronic medical records, and they include both coded and text data. Access to those records is managed through a range of different kinds of relatively small number of software providers, and there are beginning to be quite good ways of pulling general practice data out and using it in other settings. So, however, it does represent a relatively underused data set for precision public health approaches. But it's possible to link general practice data to a range of other data sources, hospital records, ambulance services, pharmacy records, to provide whole of system and whole of person pictures of people's health and their health service usage. That then means that with increasing precision, it's going to be possible to identify when to intervene, in what sorts of ways, for which subgroups, all in the interests of improving practice of individual patient outcomes. Having said all of that, the use of general practice records in this way in Australia for purposes that you could call precision public health purposes is just beginning at the moment. So the question that we've been asking for the last few years, and the work that we have been doing, is how could involving communities and publics improve the usefulness of precision public health approaches which use general practice data. The background, the bigger piece of work under which this sits, is something that's called the GP Data 2.0 project, which is focused on developing a best practice framework to enhance public confidence in the use of general practice data for research purposes, and really to build a social license to share general practice data for research in Australia. One of the components that one of the projects that we've run under this big umbrella is a community jury project. And we've run 2 community juries where we've looked at and asked our jurors to tell us about the circumstances under which they think it would be okay and acceptable to share general practice data for research purposes. If you're not familiar with community juries, they bring together diverse participants over a period of usually days and ask them to frame their recommendations against a jury charge, a question or a remit in the context of what's going to be best for a whole community. They're given plenty of time to deliberate, they exchange views, they consider trade-offs, and they have access to experts who provide them with information that's relevant to the question they're considering, and they can go back and ask for more information if they need it. And eventually, they make recommendations on the question or the charge. In our community jury, on the circumstances under which it would be acceptable to use, permissible to use general practice data for research purposes, we recruited 2 groups of jurors, 20 in each. We used a market research company for that. We ensured that they covered a diverse array of the Australian population. They weren't representative in the sense that they were in the same proportions as the Australian population more generally. Rather, what we wanted was diversity and inclusion. So we screened for people and then adjusted by age, gender, socioeconomic status measured through income, education, employment category or occupation, rural versus urban dwelling, whether English is spoken at home or not, and indigeneity, whether they were Aboriginal, Torres Strait Islander or not. So we started out with a 90-minute online session. It was actually a Tuesday evening where we brought our jurors together each time separately, and told them about what a community jury was, gave them an overview of the project more generally, and then mainly spent the time introducing them to each other in small breakout rooms and doing some skill building around what are the kinds of things that you do in a jury, and therefore what sorts of skills are you going to need to have. For each of the juries, we followed that up with a 2.5-day in-person activity where we brought everyone together to the one site. This was July and August of last year. And then they listened to people both in-house and online, telling them about a range of aspects related to the jury charge. And then they had about a day and a half to deliberate on that charge and to come up with recommendations rather. So in terms of what we told them about how general practice in Australia works. We gave them copies of records to look at so that they could see where data were extracted. We gave them case studies of how general practice data in a data-intensive way are being used for research purposes and the outcomes that that's generating. We explained how data can be shared, a little bit about how the mechanisms of sharing worked. We talked them through data linkage and privacy protecting approaches there. We gave them an overview of the kinds of ethical issues they might need to think about, the legal framework for sharing data in Australia, and then we also gave them findings from previous work that we had done doing surveys with the broader community. And as part of this big question about what circumstances do you think it would be permissible to share general practice data for research, we then said, well, think about these more specific questions that I've listed there. You're not restricted to those questions, but you might want to think about them. And before I tell you what the outcomes are, the recommendations that I made, I thought I ought to show you what a group of jurors look like, just in case you think I'm making all of this up. These are the jurors who came to our Sydney jury, and obviously with their consent, they've been willing to have a photo of all of them taken for us. And the photos that then follow are also from this Sydney jury. So what did they tell us about their perspectives? What recommendations did they make about the circumstances under which it might be permissible to share data for research purposes? And I've actually slightly reframed them to say, well, what would this mean if we were involving communities to improve the utility of precision public health in general practice in Australia? The recommendations that they came up with to address this come under 5 broad headings. First of all, there's a heading about the need to engage vulnerable groups. Then what they wanted was really trustworthy consent models, clear public benefit, good communication and transparency about how the work is being done, very strong data security, and then robust governance systems. And I'm going to talk a little about each of those by giving you some of the recommendations that they made. Each of the juries decided that they wanted to make a general overarching statement about their concerns about the marginalisation of particular populations if we are going to make use of general practice data in a precision public health manner. The Sydney jury were worried that they weren't representative of the population that we needed to consult with. So they wanted people who might have their own special reasons for being concerned about their sensitive information to be consulted more fully. The Melbourne jury, again, created an overarching statement which was specifically about their concerns about Aboriginal and Torres Strait Islander peoples and their historic marginalisation and how they would probably be harmed, they felt, by participating, by having their data included and would not benefit from it. So they began with this historic oppression statement. Aboriginal and Torres Strait Islander peoples have experienced and continue to experience abuses of power, breaches of trust, and in many cases, targeted discrimination. And that is ongoing. And we need to take that into account if we are going to share data from general practice for research purposes. So the kinds of things that the jurors were talking about in these two juries were, I think, nicely exemplified by this quote from one of the presentations from one of the subgroups to the bigger group about their reasons for wanting an overarching statement. We're worried that we're unable to make informed decisions for everyone in the Australian community. I can't make the decision for those people. We don't live in their shoes. That's why they've made that recommendation. So the second recommendation was about having trustworthy consent models. Now, remember that both juries received quite a lot of information about different models of consent, the ethical issues that raises, how information travels, how you de-identify information or not, and how it can then be used. Both juries said that they were comfortable with an opt-out consent model, and they had a range of other things, therefore, that they thought needed to be in play. If you were going to have an opt-out consent model, you needed to have information about the range of things that would happen if general practice data are used for research purposes. And you needed to tell people that you were doing this. They needed information in language and with timing that they could understand, in appropriate and accessible formats. They needed to understand the model of consent itself. They needed to know what kind of research was being done. They needed to know how data were de-identified, about who would have access to data, where that was happening, and why they were using it. I really like this quote from one of the jurors at the Melbourne jury, because I think it shows how carefully people can think about the trade-offs between having robust data collections, which an opt-out data collection set will give you to some degree. It's better, much better than opt-in. And the trade-off with not wanting it to be a completely non-consensual model, because that means that some people, as this person said, are going to be too wary to go to doctors once they find out about this, and that'll have a negative impact on their health. So they're treading the line between robust data collection and respect for people's autonomy and empowerment very carefully here. People in the Sydney jury, for example, coming back to the issue of transparency and information, just wanted to be sure that we reached as many people as possible so that everyone knew what they were getting into if they were allowing their data to be shared. Both juries wanted it to be really clear that there would be public benefit arising from making use of data in these ways. And that public benefit, they wanted to constrain that really to benefits that related to the health system and to services that are provided for patients. As you often find in other areas where you do this kind of research, they didn't want data provided where the only benefit was likely to be for private sector profit. They wanted the benefits to be for the Australian community, and specifically in health and medicine. So I guess what's coming to me is just how richly valuable the data are, so people could see how important this would be and how impactful it could be in the future. And the kinds of things they were talking about, so remember we're still post-COVID, preventing another outbreak, finding hotspots, identifying new cases and diseases, generally benefiting the population. Fourth area of recommendations was about data security and being really confident that we have the best possible data security arrangements in place to ensure that people who ought not to be accessing data were not gaining access, and that we were minimising the likelihood that there would be breaches from people of malicious intent. Both juries were really keen on punishing people and having fines and jail terms for people who access data inappropriately, and also wanted lots of checks and balances around ensuring that the people who were using data understood the importance and the significance of what they were being entrusted with. So to give you a sense of the flavour of the recommendations in this area, you can only trust people if you've got huge penalties for mistrust or misuse, and fining people if they misuse information, and if people who on-sell information, they need to go to jail. The final area was robust governance systems. For the Melbourne jury, they felt that if you had ethics committees, what you would call ROBs, I think, in the US, if you've got those in place and they had really strict and well-defined powers, then that will be adequate to ensure that governance systems are in place. For the Sydney jury, they wanted an additional governance body because they felt that at the minute we didn't really have a way of bringing all of the stakeholders together with varying interests across both public, patient, citizen groups and researchers and government and general practitioners to actually bring it all together and to work together to make decisions about who can have access, under what circumstances, and to monitor that. So a transparent framework, an independent body of some kind needed to be created to benefit not just general practice data, but they said, well, we need more of this for data security at using government data more generally. So what are the messages that I think come from this piece of empirical work around the questions that we're addressing today around equity, communities, and precision public health? What does community engagement have to offer the potentially troubling relationship between equity and precision public health? First of all, I think what it tells us is that transparency when we use people's data is absolutely essential. Discovering secondhand, in this case, that information from your general practice record is being shared, even without identifiers on it, can have a profound effect on people's trust in the health system, in general practices, and in GPs. And it will be the same in every area. People who don't trust stop accessing health services. Those health services are generating their real-world data. That is both a vicious cycle. That's a vicious cycle in terms of less access to health services, therefore greater inequity. It's also less use of health services, therefore precision public health is going to be less good, and the data that we are using will be less good. We need to engage really strongly with minority populations and with vulnerable populations to ensure that the data that we collect are collected in ways that are culturally appropriate and that build trust. These groups are going to be underrepresented if we don't do that. So within that, ensuring that precision public health outcomes are actually relevant to vulnerable communities is really important. We need to conduct research that matters to communities rather than research that matters to researchers. We need to prioritise questions that are important to communities that are actually experiencing inequities. And we need to draw on the expertise of vulnerable and marginalised communities, for example, to create appropriate data items. When you ask, in the context of my country, Aboriginal and Torres Strait Islander peoples, how should we collect data about indigeneity? You can get some quite surprising responses. what you get is certainly not always the way that we routinely think about collecting indigeneity as a data variable. So items like race, like gender, need to be informed by community understanding. And finally, including community members as researchers, including particularly community members from diverse and marginalised backgrounds as researchers, is going to be really important to identify the ways to support and to encourage data collections from those communities. So I hope that in both traversing a little bit of introductory material around the ways in which equity and communities and precision public health connect to each other, and then giving you some really concrete examples from my own recent work with this bunch of fantastic colleagues, I've created an opportunity for us to have a really interesting conversation for the next half hour or so. So I will stop sharing my screen if I can work out how to do that.
Great. Thank you so much for the presentation. And folks that are on the call, please feel free to come on camera and ask questions, or raise your hand and ask questions, or pop them in the chat and ask questions. I see some in the chat here. So to get us started, the question is, do you see community engagement as similar between precision public health and other research projects? Do you think that the same principles apply?
I think the short answer is yes. It is more challenging, and people will always say, when you're working with communities in a community engagement project and you are drawing on lived experience of, say you're working around a research project that relates to diabetes, even with minority populations, or vaccination with minority populations, then people are very much drawing on their own lived experience. And the challenge, I think, with precision public health appropriate approaches, with data-intensive approaches more generally, is people don't have that, we think people do not have that same lived experience, but they do. Obviously they do. We all have lived experience of our data being used. And I guess my work with ordinary community members has highlighted for me again and again that people bring to bear their experiences, and particularly if you can add to it extra information for them to work with about how you go about collecting data when you're using data-intensive approaches, what happens with data, how can you do de-identification, and really importantly, what happens to the robustness of findings when you do not have large representative data sets. When you can build all of those things in, people can do amazing things. So I think in general, the approaches are the same as for any community engagement project. What they share is it's really important to listen to people's experiences. What you might need to add is some skill building and content building around what that lived experience relates to, which is in this sense, often people's administrative health data. No, so the second question is, do you see general changes in how people view their data? And we've done some work on this. And it's actually the opposite of what you might intuitively expect. So we tend to find, and this has been across a number of community surveys, but more explicitly so in the community survey work that we've done around general practice data, that older people are more willing to share than younger people. Now, we think it is partly because older people have greater trust in the health services that they're using, partly because they're using them more. So I've done some work recently on what people know about where general practice data are already being shared. And older people are more likely to think that their health data is being used by everyone. Some of that relates to their experience of using health services. They're more likely to be hospitalised. The minute you go to hospital, you can see all these people looking at your health record. They're more likely to turn up in emergency services and to see who accesses data there. So if there is a trend in this area, it's a trend that suggests that older people are more likely to be willing to share data and think that data are being shared, and it's less the case for younger people. It sounds counterintuitive, but it is. It also relates to the privacy paradox problem, which is the more ubiquitous sharing of data becomes, the less trusting people are about the sharing of their data. So yeah, the more we know about our data being shared, the less we trust. No.
Great questions. So this is maybe a US kind of hat on here, but I'm curious particularly around the recommendations from the deliberative democracy groups, if there were any differences in opinion about like the institution that owns the data, right? So for us, we have Medical University of South Carolina, where people are maybe trusting that institution specifically versus another institution, or even, industry and those sorts of things. So I was curious if that came up at all, or the place that the data is being shared or coming from.
So it is important, and it's also the case in other work that we've done previously. The private sector, as in drug companies, pharmaceuticals, definitely health insurers in Australia, life insurance companies are not in general trusted as recipients of people's data. There is all of the work that I've done has a blanket no with life insurers having access to data. People just do not trust that will be used in ways that would serve their best interests or the public interest more generally. Once you get outside of that, then things are a little more murky. People trust their general practitioner to hold data about them, absolutely. They have less trust in everything outside of that. They have less trust that the public sector, government bodies will hold data and keep it secure. Now, we've had a number of quite highly publicised data breaches using public data that are held in the public sector, health data held in the public sector. And people see that and are concerned. Universities sit in about the same place. People are about as distrusting of universities holding their data as they are of the public sector holding their data. The further away you get from service delivery, okay for a hospital to hold data about me, lots of data about everyone else, but the further away you get from health service delivery, the less trusting people are. But I think what the jury's work show is that they then tend to say, well, what we need is really robust governance systems, so that if we are going to have people in universities, people in the private sector. If we're going to allow that at all, we both need really tight controls on what they can do with data, and we need that very carefully managed, and we need people to be quite transparent about what the outcomes are. And we're only going to we only want data being made available if there is a strong possibility that it will yield public benefit.
Thank you. Others on the call have questions. Otherwise, I'll take the liberty to ask a few more. Great. Julia just chimed in on the chat. She said, great to see the clear recommendations line up so well with other best practice guidance. Sorry if I missed it. Were there some recommendations from the community juries that you found surprising?
I think I would say that we did find, because I'd done lots of jury deliberative work over the years, and these were the first deliberations in which we got that really explicit overarching set of recommendation in both juries, quite independently, other framed differently, but that big picture thing that said you have to take vulnerable populations more seriously. That had not been present in any work that I'd seen before. So I think that was surprising. And probably when we take that apart and see what's going on underneath, we did talk with the Melbourne jurors right at the end when we were doing the debrief with them about their recommendation about First Nations peoples, and another recommendation that they had made about the need to ensure that people's healthcare was not diminished by making use of health data, that we didn't divert GPs into doing other things other than taking care of people's health. And the Melbourne jury made a really interesting point, and quite a few people in the jury did, which Melbourne was the most locked down city in the world during COVID. They were locked down longer than anyone anywhere else. It was months. And people were still recovering from the distrust that had generated. They couldn't get to see a doctor at all. They felt that government had completely mismanaged much of this. So some of the recommendations in those areas, there was some suggestion that it was partly in response to their experience of COVID. I think the other reason why people focused on that is general practice data in Australia are not quite like any other health data, because this is first point of contact with the health system, because people can know a GP and have their healthcare provided for decades, also might have their children's healthcare provided. GPs will know things about you that no one else does. They may or may not get written down in the health record, but aspects of people's lives that they don't always see as being their health, their social lives, get picked up by general practitioners. And I think people are far more sensitive about general practice data use. So probably that then feeds into this concern about vulnerable populations and people with particular reasons for distrust of data sharing. The other one that I should stop being surprised by is the way in which people respond to trying to manage the likelihood of breaches, which is we're going to jail everyone. I've seen it before, but I'm always surprised by how you can. And our legal expert, actually told both juries, because they asked, no, there's very little evidence that fining people actually makes much difference with respect to malicious hacks. And fining large corporations doesn't necessarily, unless you're doing it to the extent that it's going to undermine their viability as an entity, it doesn't seem to have much impact on things. So you can say that and people still think, let's fine everyone and let's put them in jail. So that's probably the other area. I shouldn't be surprised, but I am.
Thank you. So we're right at a couple minutes until the close of the hour. So I will maybe ask the last question, which is how, I guess in the past, have you used and kind of plan to use with this new deliberative democracy work, use that information and actually implement it for making changes in precision public health research?
So that's the really important thing, I think, here. The hope that one builds amongst, say, a jury where people put a lot of effort and time and engage intensively. The hope that you build in them that this will lead to something else is really acute, and I think we have to be responsive to that. So, as I said, it's part of a bigger project. We have done earlier work, which is broad survey work. We are in the middle of doing work with general practitioners, where we're feeding them the jury recommendations and saying, does this work? Would this work in your settings? Why and why not? We've then got a set of consultations with regulators, policymakers, ethics committees, and we then go from that right at the end of the project to a roundtable, which is really focused around policymakers and regulators. The groups who we have as partners in the project actually include, at the Commonwealth level of government here in Australia, the sectors of government in the Department of Health who are in a position to contribute to rewriting legislation. So it's taken a while to build that coalition, but we've now actually got partners across an array of areas where there is where they're engaged, they're keen to see the results. You know, promising that you'll change the law, particularly privacy law in Australia, is a bit much, but we still all hope that at least if we don't get that, we will end the project with everyone actually understanding that what we have in our privacy law and our data sharing legislation at the moment is not fit for purpose, and it's got to change.
Great. Well, thank you so much for your time today, Annette, and your wonderful presentation. I think it's a great way to kick off our conference that's coming up next Friday, focused on health equity and precision public health. So I'll certainly be sure to reiterate a lot of the talking points you shared today during that meeting, and look forward to seeing many folks on this call at the conference next week, and hope everyone has a great evening that's on the East Coast, and has a great Friday if you are elsewhere.
Well, thank you so much, and all the best for your conference.
Thank you. Bye, everyone.